Bhavini is a hospitalist physician based at South Health Campus, and she has a position at the University of Calgary. And she's also the section chief for Medical Inpatients for the Calgary zone. That's not what she's talking to us about today directly. I've had the great pleasure of getting to know Bhavini over the last year or so as we've crossed paths in a number of areas related to sustainability and in the healthcare system and planetary health challenges in general. And I'm really excited that we're able to convince her to come and talk to us today. She's a very dynamic speaker and ambitious person, and is going to really, I hope, inspire you all as she has me about some of these issues. So her talk is titled Healthcare During the Anthropocene Era, and we really look forward to seeing it. So thank you and welcome.
Thanks so much, Steve. I'm just going to share my screen. Right. Right, you can all see that, right? It's working great. Okay, wonderful.
Yeah, that's
okay,
great.
well, great. Okay. Well, thank you so much for having me here. I appreciate it. I'm excited to be here and talk to you all today about this really vital and crucial topic. I always find the climate crisis extremely mentally burdening, and I think for a lot of people, it definitely causes a lot of stress. But I'm hoping that my talk will allow you to look at this in a way that, there is a way that we can make a difference and tangible strategies that we can actually move forward with in order to sort of contribute and sort of change the path and the course. So to start off with disclosures, I do have personal investments in fossil fuels, which I'm trying to change. As part of sort of some of the work that I'm doing on personal development, I am doing a master's in global health leadership at Oxford University, which does require me to do 5 trips back and forth to London. I was quite shocked as to what that was equivalent to, which is about 3.3 homes of energy use for 1 year and about 4.3 passenger vehicles in a year as well. So I'm going to sort of start off by talking about the climate crisis, the impact actually on healthcare, and healthcare's impact actually on contributing to the extremes in weather. I'm hoping to provide tangible ways to engage healthcare workers in the climate crisis, and then also encourage dialogue and innovation in climate adaptation, resiliency, and building a sustainable healthcare system. And please sort of throw things into the chat, and we'll sort of get to them at the end. So to provide a little bit of background, some of you may have heard this terminology called the Anthropocene phase. It's interesting because I was reading a recent article. There's still a little bit of sort of back and forth from the climate scientists to say, are we truly in this new geological era? We're definitely in a different geological era. And the Anthropocene phase is really humans are the primary drivers of changes in the climate. And the Earth operates within sort of 9 planetary boundaries, and we've already transgressed 4 of them. And that's why we're seeing a disturbance in that equilibrium of the planet. And that, unfortunately, is leading to big impacts that we're seeing on health. So we're seeing changes in vector ecology, so starting to see malaria in areas that we never used to. Canada particularly is going to start seeing more Lyme's disease. Of course, with air pollution and extreme heat, we're starting to see increase in cardiovascular diseases as well as respiratory diseases. And those people that have those comorbidities are coming in with exacerbations during sort of summertime, as well as that malnutrition in certain parts of low middle income countries. And what a lot of people don't understand is this is actually going to become a military issue. We're going to see forced migration and civil conflict. Syria was actually partly due to climate crisis and issues with water, and that's why that civil conflict happened. And as well as that, something that is not actually on this diagram by the CDC is the change in biodiversity. And that change in biodiversity is going to lead to a lack of access in medications. And the one thing that I would say is that our vulnerable are going to be the most affected, and they're going to have a harder time recovering. So it's important that healthcare really starts stepping up with this. And many of you may know this, but there are, of course, big cardiovascular risks of climate change. And I really like this diagram because you've got the heat events and air pollution, but it also highlights that it's again going to be our vulnerable that are going to be affected. So those with low socioeconomic status, age, and those people are going to be at more risk of sort of cardiovascular morbidity and mortality. And we've seen that there are direct and indirect increases in cardiovascular morbidity and mortality. We know that extreme heat is actually leads to increase in cardiac workload, and we've seen increase in cardiovascular disease related emerge visits as well. Flooding and destructive windstorms, and post-hurricane, we've seen an increase in number of heart disease and death related to that. Particularly in Hurricane Katrina, a week after landfall, there was an increased cardiovascular disease rate amongst these people. And then there was an increased mortality from myocardial infarction that was actually demonstrated after Hurricane Sandy in 2012. And there was an increase of up to 22%. So really important for your department, because you're going to start seeing that increase in demand needed when we're seeing that those extreme weather events. But what about the impact actually on healthcare delivery itself? So, as well as the changes in volume and pattern on healthcare demand, so morbidity, mortality, forced migration, we are going to see disruptions in our building infrastructure, travel energy infrastructure, supply chain, and as well as staff shortages. And I'll talk a little bit about this when the things that we saw with the impacts of these weather events in Alberta. One of the things that happened with the hurricane that happened in Puerto Rico, is that we saw a shortage of medical supplies. And I think what a lot of people do not realize is the COVID pandemic was partly related to the climate crisis. We got too close to nature, and it really provided us a taste of what these demands and constraints are going to be, and highlighted how globally interconnected we are, and how a supply chain issue here is going to have a big impact on us here. The impact in Alberta has been pretty significant. Actually, 4 of the costliest disasters in Canadian history have occurred in Alberta. The 2023 Alberta wildfires cost Alberta Health Services about 7.8 million in direct payroll costs, travel costs, supply expenses, evacuations. You know, we saw numerous things happen. There were staff shortages because of the direct health impacts to them, disruption in transport routes, closure of specific departments. There was, a lack of access to basic care, infrastructure damage, and of course, transfers of patients from affected facilities. And the floods in Alberta in 2013, this was actually the start of my career. I started as a hospitalist at Southall campus, and we had a list of like 40, 50 patients as we were trying to increase our capacity. And all of a sudden, we took all the patients that came in from High River, and our census went from 50 to like 100. And so we were handling close to 30 patients each. We saw damage to multiple hospitals, urgent care centers, continuing care centers, as well as that, as 1,000 patients were evacuated into the Calgary zones within 24 hours, and staff were also displaced from work as well as their homes. Now, it's very tough to sort of look at the annualized cost of this in Canada, because it's so difficult to know. But between 2013 and 2018, they estimate that the annual economic valuations of the health impacts for acute health impacts was about 410 million to 1.8 billion, and the chronic health impacts being 4.3 billion to about 19 billion. So Health Canada actually recognizes that this is going to be extremely costly for the healthcare systems. So actually, healthcare itself has a significant impact on greenhouse gas emission on the climate. If the global healthcare sector were a country, its emissions would be the 5th largest on the planet, just ranking behind Japan. And the Canadian healthcare sector is among the top most carbon-intensive healthcare polluters, resulting in about 5% of Canada's total greenhouse gas emission. And actually, we probably surpass now the country's aviation sector. So that says a lot. And it's not just carbon dioxide that we're emitting. We're emitting methane, nitrous oxide, hydrofluorocarbons from anesthetic gases and asthma inhalers. And of course, we have the plastic pollution, the water pollution, the deforestation, and depletion of scarce material. So this is actually information hot off the press, but AHS admitted about 2 million tons of CO2 in 2022 and 2023. That's cost us 14.5 million in the carbon tax. And obviously the government has increased that. So by 2030 and 2031, that's going to go up to $50 million a year. So significant cost to the healthcare system. And this is really coming to the forefront. So it's not like, okay, that, this is sort of hidden news. So we know that Canada's healthcare system is among the least green. They did a study in Waterloo and they found that one hospital bed day actually equates to 5 household energy use in a year. And what's really interesting is Canada's total carbon footprint per capita is actually extremely high. I work out in India, and for some reason, I'm always stuck there in Delhi when it's completely polluted, and their cooking practices, the energy type that they use, and the sheer number of people they have in India, you would have expected their carbon footprint to be high, and in actual fact, it's not. We have a much higher footprint than places like India. So what's healthcare's responsibility in all of this? So healthcare's responsibility is we need to be building climate resilient and adaptation strategies to actually tackle what I call the VUCA, which is the volatility, uncertainty, and complexity, as well as the ambiguity of the climate crisis, to create a really agile healthcare system. We have to be leading by example by reducing greenhouse gas emissions while promoting a sustainability in the entire medical supply chain. As well as that, we have to be building healthcare operations that are safe and that reduce environmental impact while creating that sustainability. And we have to be training our healthcare personnel to recognize and understand the effects of the climate crisis and to be advocating, and with that also sort of reduce the carbon footprint in order to build resiliency in the healthcare system. Now, a lot of work has been done within the National Health Service. Why? Because the National Health Service is the first healthcare system in the world that's essentially said that we're going net zero. And with that, they've done tons of work on their carbon footprint. And if you look at this sort of pie diagram, it clearly shows that 62% of the CO2 emissions actually come from medicine, medical equipment, and other supply chain. And whereas only sort of 10% come from building energy and 5% from water and waste. So in AHS, we've left a lot of this up to capital management. We have to be involved in this in order to bring that down, because capital management can't just look at our building energy and our water waste and be like, okay, we're going to meet those targets. And NHS have clearly seen that they're not going to meet those targets if they don't have everybody in the healthcare system contributing to get them to net zero. And you can see that the healthcare hotspots, again, being mainly acute care. So really those medicines, chemicals, and medical equipment that really seem to be the hotspots in terms of the CO2 emissions. And this diagram sort of illustrates this very nicely. What's really interesting about this is the anesthetic gases. Now, in the UK, they've completely moved away from desflurane. And if some of you know about desflurane, it's an extremely it has a significant impact on the environment. And in the UK, they've completely banned it. What I've actually found out is that there's only really one supplier now internationally. So we continue to use desflurane. And so for us, we need to be moving away from that. So actually our anesthetic gas contribution is probably much higher than the UK. And again, sort of the medical instruments, the pharmaceuticals, huge impact, far outweighs the sort of the energy impact that healthcare actually has. And so as part of this, and again, I've taken this diagram from the National Health Service, is the National Health Service sort of looked at sort of what is their projected increase and what initiatives can they do to actually bring down that carbon footprint. And you can see by the red dotted line, if they do nothing, they're on par to actually increasing their greenhouse gas emissions. And this is sort of their emissions per month within the full NHS trust in England. And the wedge diagrams show initiatives that can be done to move that dial towards achieving that net zero. And everything from the red arrow down is essentially initiatives that that we need to be involved in as clinicians to actually achieve that net zero. So things like low carbon models, moving to digital care, looking at our sort of prescribing as well as our sort of investigation habits as well. Looking at preventative medicine, and then being sort of stewards in terms of looking at the food chain, looking at sort of more of a plant-based diet and sort of turning off lights. So really, we need to be engaged in order to start moving that dial. And NHS has clearly recognized that and is saying, right, clinicians need to step up and be part of this work if we want to achieve that target of net zero in 2040. So this was really interesting because I wanted to look at the environmental impact of cardiovascular healthcare. And actually, I found a systematic review that was done in 2023. And it was 12 reviews, and 8 of them actually were used the methodology of life cycle assessments, which is actually the gold standard when you're calculating your carbon footprint. So these were pretty good studies. And what they found was that cardiac imaging really offered sort of the biggest opportunity in terms of bringing down the carbon emission. The authors found that there were ample opportunities that the cardiologists could intervene in. And in actual fact, they found that in these studies that people were really motivated to do this. We're not looking at costs now, we're now looking at sort of the carbon footprint. And we know that bringing down the emissions is going to have the co-benefits in that health. And when you start reframing this, you found that engagement. They found things like remote monitoring pacemakers had a big impact, the prescribing habits. There's that real balance between sort of making sure you're prescribing the right medications to keep them out of hospital, but you're not sort of overprescribing or causing sort of adverse drug reactions and polypharmacy that they end up in hospital. So, our frail elderly patients whose blood pressures are tanking and they fall, and then they're coming to me. So sort of having that really good balance. And then, of course, looking at your test ordering as well. And then looking at waste within cardiac surgery and within the cath lab. So these were sort of the key things that they felt that the cardiologist and could really have a big impact on starting to actually move that dial. So one of the things that I found with this is, a lot of people saying, okay, how do we do this? How do we start engaging healthcare workers? And one of the strategies that I've sort of been involved in is looking at embedding this into QI methodology. So at South Health Campus, we partnered with the Centre of Sustainable Healthcare in the UK, and they work right across the UK amongst many health services within the NHS to actually start embedding sustainability into QI. And the Centre of Sustainable Healthcare, they started back in 2008 with a view of these principles. They knew that that preventative care and promoting preventative care was really going to be the biggest bang for your buck in terms of reducing that carbon footprint. If patients don't need to access the healthcare, then we're bringing down the use of healthcare, particularly acute care. Also empowering patients to take a greater role in managing their own healthcare, which is something that really, really surprised me. And then thirdly, sort of lean service delivery. So minimizing sort of system wasteful activity. We know there's a lot of repetitiveness. We know there's a lot of waste in our healthcare system. And then finally, where we get involved is looking at the low carbon alternatives. So these were designed in order of importance. And they're using these principles, they use this to develop a framework of QI. So they looked at sort of secondary drivers that feed into reducing those primary drivers. So reducing carbon intensity and reducing activity. And those secondary drivers that sort of reduce activity were sort of looking at preventative care, self-care, and lean pathways. And sort of reducing carbon intensity was sort of low carbon alternatives and operational resource use. So those things can essentially drive down and reduce the carbon impact without reducing the healthcare for the patients. And with that, they developed something called the SUSQI framework. So this was developed along with the Royal College of Physicians in the UK. And the SUSQI framework is an innovative tool which links carbon reduction and sustainability to the core mission of providing the best possible care. So it's not a replacement for our AIW framework that we have within AHS, but it's actually adding an extra domain of sustainability. And when you add that, you're sort of looking at the triple bottom line. So the environmental impacts, the social impacts, and the financial impacts. So ultimately, you want to deliver the best possible healthcare outcomes with minimizing the financial, environmental costs while adding a positive social value. And when they studied this, they found that post-COVID, I think everyone can attest to the fact that morale and motivation has been significantly low within our healthcare staff. But they actually found that SUSQI had the potential to reverse this negative trend, and it actually has been shown to engage and motivate learners. And that's something that I've seen just with the small pilot that we've carried out at South Health Campus. Both myself and our QI consultant at South Health Campus has been trained in this, and we're now offering SUS QI framework. And because we've been trained in this and we're now offering training, we've officially become an aspiring beacon site at South Health Campus. And actually, probably in the next couple of weeks, we'll officially become an internationally recognized beacon site, which means that we're starting to embed sustainability into QI frameworks, and we're recognizing that this is actually important. So we're pretty excited about that. And one thing that was really interesting with the SUSQI framework is the big sort of thought around social impacts. When you're starting to make big social impacts, you're going to be reducing down that carbon footprint. So when you start looking at your supply chains and interrogating those supply chains and designing interventions to target social determinants of health and building social values, you're automatically going to bring down that big carbon footprint. And we actually took this through a project that was done between September and December 2023. So we took something called the Walking Wounded Initiative, whereby these patients had fractures. So these were orthopedic patients that had fractures, youngish patients that could essentially stay at home and wait for their surgery. We knew they needed urgent surgery, but felt that they didn't need to wait in hospital for a bed. And what they did was they set up sort of a whole pathway for patients to wait at home and then be called back once they're going to have their surgery, and then essentially be discharged the next day or the same day. And what we found was that we avoided 320 overnight hospital stays over 4 months. That equated to around $370,000, but avoided about 12.25 tons of CO2 emissions over 4 months. And of course, patients are much more satisfied staying at home as long as there's a proper pathway and protocol in place. And they were much more satisfied with the process that they had versus sort of sitting in the hospital waiting, not knowing when they're going to go to the OR. So in terms of the carbon footprint, like how did we calculate that? One thing I would say that there is no exact science. It's, calculating sort of the cost of certain things is challenging. You can only imagine what it's like when you're calculating the carbon footprint. And unfortunately, we don't have carbon factors specifically for Canada. We have a bit of US data, but a lot of it comes from UK data. So, one thing I want to highlight with this slide is that this isn't a precise science. And if you want to get into precision, you really have to go into doing life cycle assessments, and you have to have the funding to actually calculate your own carbon factors within your own region. So we are using UK data. So if this is something that you guys say, you know what, we want to embed, we can absolutely support in this work and try and help with the carbon calculation, because it can get a little bit complicated. So if we look here, one overnight bed stay equates to about 39.4 kilograms of CO2 emissions per day. And when you times that by 320, that's where we got the 12,000 from. And then we had to minus obviously the back and forth trips, as well as the phone call and the energy used. And that's where we came to that figure. And when staff look at this, are like, huh, what does this mean? Like, I don't understand what this means. This is where we actually use Canada's greenhouse gas equivalency calculator, because it really helps staff to say, oh, this is what it means. So in this case, 12.25 tons of CO2 is essentially 3.8 passenger vehicles a year, or equates to about 2.9 homes of energy use for 1 year. And when you start showing your staff this, and your your nurses, and your physicians, they're really like, oh my goodness, that's the impact. And this is where you start really seeing that engagement in doing this work. As part of this, we've also officially got funding to actually launch what we call the Green Team competition. This is an award-winning program that the Center of Sustainable Healthcare is supporting us in, and they're sort of helping us sort of engage, support, and take teams through this whole SUSQI process. And we've got sort of 6 teams that are officially participating. We've got Allied Health that are doing some capacity, looking at the capacity process. We're looking at the Department of Anesthesiology is looking at desflurane. Emerge is actually looking at ketorolac, which is quite interesting, and the use of ketorolacs and the mini, and sort of how they're administering it, and mini bags. Neurology is actually looking at virtual clinics. The surgical suites are looking at the Striker program, and the wellness kitchen is also looking at virtual programs. So we've officially launched the Green Team competition, and the uptake and the engagement has been really impressive. The final judging will be held September the 19th. So this is sort of what 2 of the initiatives that are actually happening at South Health Campus. And with the Green Team competition, I think what I want to highlight here is people just think this is just, okay, let's just recycle. No, there's much more that I think healthcare systems need to be doing other than just recycling. Looking at sort of PPE, particularly for you guys, in Southampton, they looked at early mobilization in the cardiac intensive care unit, and they found a saving of $1.2 million, pounds, in 2 years, which equated to about 48 tons of CO2 over 2 years, which is pretty significant. And of course, looking at things like reducing unnecessary cannularization, or looking at reducing routine blood work in our elderly patients. So you can see it's just much more than recycling. And I think this is where people get a bit sort of tripped up, like, oh, well, I don't know how to do this. Well, actually, you're probably already doing some of this work anyway. We just need to capture that in sort of a carbon footprint. Now, one of the things that has really sort of come to sort of light as I've been doing this work is that, well, we know that this is healthcare's responsibility. We know these 4 things are our responsibility, but how do we do this? Like, how do we tangibly do this at a health facility level? So particularly within acute care. And the WHO has come up with an operational framework for building climate resilient healthcare system. And this operational framework was particularly designed for low middle income countries. And it really transcends across the whole healthcare system, including public health. And there's no real clear framework that says to acute care that this is how you do this work, and this is how you embed it. So as part of sort of some of this work we're doing, we're starting to say, okay, this needs to be bigger than just QI and the Green Team competition. We really need to look at all avenues of sustainable healthcare, including our supply chains. We also need to look at building resiliency in our healthcare system. As a hospitalist, I don't get a break in the summer. There used to be a time where we used to be like, okay, it's the summer, we can have a break. But no, we're getting, increase in CO2 exacerbations, worsening heart failure. Just like the neurologists, they're seeing more strokes. The surgeons are seeing more appendicitis, and you're going to be seeing more myocardial infarctions. So we really, as a healthcare system, need to start getting ahead of the game and make sure that we're starting to build a robust, resilient system to withstand this. So as part of some of this work, we are looking at developing something called pillars, where strategies will sit under. Right now, these are still being interrogated and being developed, but we've looked at sort of 6 pillars that we think that strategies can fall under, that zones as well as the provincially thing, we can carry out these strategies and they'll sit under these pillars. So there's resiliency, which I've talked about, sustainability, one of these things being sort of the SUSQI initiative, as well as the Green Team competition, but also looking at our supply chains as well. Quality improvement, which is again where our SUSQI framework sits, looking at a proper leadership and governance structure, committing ourselves to say, you know what, we need champions in our department to be doing this work. Putting this in your strategic plans are going to be really important because that will force your hand to actually build a governance structure around this. Creating education awareness. We have mandatory modules that the province asks us to do. Making the climate crisis a mandatory module is going to be really important to educate our staff, because a lot of our staff don't know about this. And then, of course, embedding this into research as well. And you see later, there seems to be a lot of interest in embedding this in PRIUS grants, CIHR grants. So by having these pillars, we can start housing these strategies and start creating a framework that I think health facilities like ourselves can sort of move towards. And in terms of talking about particularly the building the resiliency, COVID really interrogated our traditional disaster management frameworks. They didn't work. And that's because we didn't realize how globally interconnected we are. And the International Governmental Panel for Climate Crisis essentially has come up with this adaptation disaster management framework. And they look at this resiliency. And this actually transcends many of the strategic clinical frameworks out there. So things that I feel like are sort of high yield that we should be doing is monitoring tools. We as departments should actually be looking at and monitoring our data. What are we seeing in the summer months? You know, what is the impact that we're seeing in Alberta on strokes, cardiovascular disease? So using our monitoring tools and saying, okay, we need to start looking at what extreme weather events are doing to our, to the change in the type of patients that we're starting to see and the patterns as well. Collaborative culture and creating a sense of purpose and cross collaboration. What's been really exciting for me to see is the degree that departments actually want to work together. And this is the first time that operations is actually working closely with capital management. Usually they're very separate, but this time we're actually working very, very close together. And as well as that, departments are starting to come together. And when you start having departments come together, you start creating redundancy. So-and-so has this resource. Well, maybe we can use that resources to support this so we can actually increase our capacity. Building partnerships, whether it be internal, external, identifying where we've got flexibility to sort of withstand the shocks of the climate crisis. Innovation is a big thing, right? We knew that High River was going to struggle. Well, how are we going to get healthcare? We've got to be switching quickly to other methods that we can actually deliver care. During COVID, the hospitalist group knew that if they were going to struggle with 300 patients, that we had to have a virtual option should our physicians need to be sick and are staying at home. So we actually set up a process of that. So looking at innovative ways that you as a department could be delivering care when when we're dealing with, big weather events. I want to sort of touch on sort of an organization called Cascades. So Cascades, it has funding from the federal government to actually support some of this work. And Cascade basically strengthens capacities of healthcare systems across Canada to transition towards low quality, low carbon, and sustainable and climate resilient care. And they have multiple sort of strategies and care pathways and system enablers that they talk about. And if anyone's interested in knowing more about this, they offer a range of courses, from introduction courses to more sort of in-depth courses on measuring carbon footprint that you can actually do. And they even offer playbooks in certain departments of things that departments can actually be doing. So Cascade seems to be leading a lot of this work right now in Canada, and we're working quite closely with them with the work that we're doing, because they're also learning. Because again, it's been really tough to figure out a framework of actually embedding this into acute care. So what's currently happening in the Calgary zone? So we've officially struck a zonal committee. I'm excited to say we do have a champion from your department that's going to be sitting on that. The idea of the zonal committee is really to develop a blueprint for other zones and for the province to see how we can actually start, embedding adaptation, strategic resiliency, and sustainable healthcare into the healthcare system, where we're looking at cross collaboration, resource advocacy, creating a research platform, which we've already started actually doing, and a raising awareness campaigns. We know that departments want to do this. The level of engagement and motivation has been significantly high with this work. That we've had to develop the zonal committee, regardless of not having clear funding, but having zonal endorsement. The surgery and anesthesia departments have got 40 initiatives that are underway provincially right now, from recycling to looking at the anesthetic gases to looking at low flow anesthesia machines, striker programs. So they've got tons of things going on right now, which is really impressive. Nephrology is going to be launching a green campaign. They're looking at sort of their dialysis flow rates and their acid bath waste. The clinical neurosciences are looking at embedding this in their strategic plans. They've looked at putting a champion in green team competition. There's a bigger discussion about actually doing a systematic review on the impacts on the cardiovascular as well as the neurological health that it has on patients during these wildfires and extreme weather events in Canada. Of course, we've got the SUSQI and the Green Team competition that's been launched at South Hill campus. I've officially started training along with Yelena, my QI consultant, at South Hill campus. Our first workshops, 15th of May. We'll be running those. So if you are interested, get in touch with me and we'll start sort of putting this out to the department that we're training people. Rheumatology has embedded this in one of their CHR grant. Endocrinology has a Prius grant that we've actually embedded that into. And we're seeing more and more departments get on the bandwagon because they are really passionate about this work. So what can you do as a department? Make this a strategic priority. For the Department of Family Medicine, I've worked with the department to actually put planetary health as a strategic priority. Delegate a champion with the department to support this work. They will sit on the zonal committee and support local priorities and building that framework. I recognize that every department's different and we need to understand that. I recognize the culture is different. What's important to one department may not necessarily be important to others. So really developing tailor-made strategies to those departments to do this work. Prioritize the pillars and strategies that have high yield in your department. So if you feel this is something that is low-hanging fruit that we can do, well, prioritize that. Allocate funding for this through your strategic clinical networks and research grant. And, embedding this simply as an addition to your research grant also starts bringing this to the forefront to show that we're not just looking at the patient outcomes, but we're looking at the environmental impacts as well as the financial impacts, encouraging research and innovation, and of course, doing education and awareness campaigns. And this is where your green campaigns come into this. They can really sort of bring this to the forefront. And of course, prioritizing the resiliency pillar. We were somewhat prepared for COVID, but in other aspects we weren't. So really starting to build that resource slack within your department and looking at monitoring tools and innovations so that you guys have the ability to pivot when there is an issue and people have to be evacuated. And what about your department specifically? So these are some suggestions that we've sort of talked about. And I think one of the biggest things, and I have to thank Andrew for this, was reframing this. And I think reframing is really important. And we do a lot of this when we look at sort of health systems and sort of health system strengthening, is actually reframing the problem. I think we've done, I think as a healthcare system, we always go on about cost, 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 cost. Great. We've put on the cost of ECGs on, I remember on SCM and echoes. Did it really change the dial? When you start reframing this to say, this is sort of the impact that we're having on the environment, the needle changes because I don't think there's anybody that wants to say that we want to damage the planet, right? And I think when people say that actually I'm contributing, my little thing that I do makes a big difference. So actually reframing that, and we've seen that with SUSQI, really starts motivating individuals to participate in the work and actually move that needle. There's things like home cardiac rehab, which I understand that you're already doing, but making that much more robust. Your remote pacemaker monitoring, which I understand is already being done. Looking at your prescribing practices as well, and also cardiac surgery, looking at the waste that's being produced in cardiac surgery and in your cath labs. How can we sort of really start looking at, reusables? And there's some work that's being done within anesthesia. And what's really great about this work is we have procurement and supply chain people that have reached out to us saying that if you are making a change, get us involved from the get-go, and they will plan accordingly. So if you feel there's something where, you know what, this is really wasteful, are they reusable options? And I don't know that, but it's for something for you guys to decide. But that is something we can absolutely support and look at. And embedding sort of SUS-QI in your QI methodology. So, within your QI, departmental QI, can we start embedding some of this work? And then also looking at a green team competition. There's been a lot of appetite with nephrology as well as clinical neurosciences about running a green team competition. Do we look at a head-to-head competition between your department and the two other departments? I think that would be really, really interesting. So, I'm interested on your thoughts and ideas, and feel free to sort of stick them in the chat. And then, at the end, we can sort of talk about these things because I think there's already things that you're already doing. So why don't we capture, the difference that we're making in our CO2 emissions? And what are our goals beyond beyond this pilot? So we're really looking at sort of spread and scaling this work. There are multiple briefing notes that have been done in a zonal and provincial level. We do have a zonal endorsement. We actually have endorsement now from our COO to actually do this work. And the hope is that we can actually create pillars that inform strategies at a zone and provincial level. We are wanting to create a leadership and governance structure for this work. We know that provinces across us trying to do this work and trying to embed this within acute care. We also have a very strong collaborative relationship with the Office of Sustainability. They've done a lot of work on carbon emission savings, and there is a lot of work still need to be done, and they're happy to engage in that dialogue and conversation. We've had a lot of discussions about dialysis machines because we know that they produce a lot of waste. So there's been some good conversation between nephrology and the office itself. We also want to align ourselves with national institutes and sort of implement adaptation sustainable frameworks that actually support what Cascades is doing as well. Of course, I would love for AHS to actually become an internationally recognized beacon site provincially. And they're starting to embed sort of environmental sustainability into the residency curriculum. So in actual fact, nephrology seem to have actually got their fellows involved in this work now as well, to encourage them to start looking at this, and embedding this into QI. And of course, the work that we're doing, we have to make sure that translates into community. And community's been doing a lot of work in this area. So we want to ensure that we're starting to sort of see that bridge with community. If we're changing sort of our prescribing practices, well, that needs to be translated and communicated across the community. And that's going to be sort of bigger work that we are hoping to do in the future. So my take-home points for this are that the climate crisis will require healthcare systems to adapt, to become resilient and agile and sustainable to manage the shock and disruptions. And this will require leadership and governance at all levels. We know healthcare systems are big contributors to the carbon footprint, and we have to be environmental stewards. And this is going to be a collective effort. This isn't going to be me by myself trying to push this agenda. Everyone has to engage in this. We know that policy plays a big role on this. And unfortunately, right now, the federal government doesn't have policy. And I suspect it's one of those things that they just haven't got the bandwidth to cover, or they don't really truly know, what each of the facilities' carbon footprint is. Montreal's doing actually some work on this right now and really looking at their carbon footprint. Finally, healthcare workers are pivotal in this role. They can leverage QI and other methods to improve sustainability in the healthcare system, which has the co-benefit in financial savings and capacity building as well. And so we have to engage our healthcare workers and ask them to become environmental stewards. So I'm going to stop there and open the floor for questions and comments. I hope I haven't scared or depressed anybody.
Hey, thanks so much, Bhavini. I have a question. I'll start off, if that's okay, Steve. It's interesting what you had to say about prescribing and how the pharmaceutical industry is such a big contributor. Could you give us some kind of guidance on how you personally approach that issue with prescriptions and where the low-hanging fruit is? How do you make sure that you balance the benefit versus the harm of medication drugs?
Absolutely. I think there's really, I mean, if I look at my elderly patients, and I'll talk about prescribing and investigation. So we know, actually, I'm going to a talk on the Choosing Wisely campaign, and they're really looking at this now on the low-hanging fruit. For instance, in my elderly patients, Zopiclone being a prime example. I think every single one of our elderly patients, wants Zopiclone because they can't sleep in the hospital or have been on Zopiclone. And we know that from a geriatric standpoint, that we really should not be giving our elderly patients Zopiclone. So looking at sort of the really low hanging medications like Zopiclone, right, has been one where I've been quick to actually take it off or provide a plan to the family doctor to actually wean them off. Of course, if they're 96 or 97 and they've been on it for 20 years, there's no way I'm going to convince them. But if, these are we seem to be starting these medications in hospital a lot, right? And we've got to be mindful of making sure that when we're discharging patients, we're clearing up medications. As a hospitalist service, we've done a lot of work on indication. We've really looked at our med reconciliation, and we've had our pharmacists at Southall campus. We're very spoiled. We have pharmacists on every unit. So we actually spend a long time interrogating their medications because we know our elderly patients come in with the side effects. Looking at our, and this is probably relevant to you guys, is our blood pressure guidelines for our elderly patients. If they've come in with 5 or 6 falls and we're seeing their blood pressures and their postural dropping, we're pulling back on those blood pressure pills. Of course, balancing that with everything else, like if they've got heart failure as well, where's that sweet spot? So we've really started looking at things from a lens of, okay, what's the impact on the patient? How do we prevent admissions? Because we know Zopiclone causes falls. We know that they get very sedated. We know the outcomes are poor. So pulling off those sort of really low-hanging fruit. And then one thing that we tend to do as hospitals, looking at the goals of care. If they're an M2 or a C1, at that point in time, we've had that conversation. Do they really need to be on their statin? What is their prognosis? And I know the pendulum swings, and some of the work that I've done with my Care of the Elderly hat is really interrogate the literature. Like, what are we seeing in terms of prognosis here? If they've had numerous admissions with heart failure and sort of like, okay, and they're on atorvastatin, we know the prognosis is, and we can tell their palliative, their performance score is very low. We're pulling back those pills. And I think that's some of the work that we've done as a hospitalist service, is really looking at the indication, the prognosis, the patient's values, are taking all of those things into account. And those are things I think that are easy, low-hanging fruit that I think we can work on. Your statins, your blood pressure pills in our elderly populations, and we can study this. We can look at sort of the admissions, and are we seeing more admissions? Are we seeing side effects? So that's kind of the strategies that we've been using. Of course, looking at the Choosing Wisely campaigns and trying to sort of stick to those as well.
Hey, thanks very much for that.
So Bhavini, that was great. Not so much a question because I probably asked you all the questions I had, but a comment is, I think things that are important to emphasize that you mentioned are that there really seems to be building organizational support at a high level for this work. So it's not like you have to sneak around and do this kind of work anymore and be afraid that someone's going to get mad at you. I think it does seem like at a high level, people are supportive of this. And for sure AHS has a mandate to, save some money in the next short while. And I think when we're starting to plan some initiatives, that's one of the key benefits that we're going to be proposing, right? Is to say this is not just about the trees and the planet and the future. It's about actually saving money this year for the healthcare organization. And that's a really important co-benefit. I wanted to ask you about, you didn't talk about so much about talking to patients directly about managing their risks related to climate, and in particular in the summer. Have you started to do that, and do you have good strategies that work?
Yeah, so we've started engaging. We did engage the CAT team in this work when we initially started, Citizens Advisory Team, when we started the SUSQI and the Green Team competition. And one of the things they articulated is that this is really, really important to them. And they actually didn't even think about healthcare's footprint. So it was a little bit of a shock to them as well. As part of the Green Team competition, we are going, and this is very new. As sort of Steve alluded to, we've seemed to be moving ahead, but when we initially started, we recognize this as a politically sensitive topic. So we've had to be a bit mindful when we initially started the SUSQI initiative and the Green Team competition. There was quite a bit of forth from AHS communications, but I think once they understood, I think it sort of fizzled out, which has been quite nice. So as part of the Green Team competition, we are going to be engaging patients. I can tell you right now that, yes, we've done the SUSQI methodology, but we really haven't had that sort of, the direct conversation with patients. We've engaged CAT. We know that they say this is important. This is going to be important for the patients. And so our Green Team competition is really going to start sort of bringing the patients to the forefront and having those conversations with them. So that's something we're going to be looking at and analyzing. My hope is that I think that we have to be mindful on how we're communicating this to patients, because, there's a trip, we know that the social value is going to be really important to them, and making sure that we understand that there's a big social value to this. So it's been, I would say right now that apart from the CAT team, I haven't sat down and said to patients, from an environmental perspective, that, we can reduce your length of stay. No, it's more sort of, we have had engagement from them in surgery, for instance, where we've asked them to bring their own reusable cup in their own bag. They've been very on board. Patients are like, actually, this is great. We're saving waste. So we know that those things is where we can really engage them. So, in the cath lab, if you're bringing them in, let's look at just asking them to bring their own bag and put their belongings in there, because that's what surgery is doing right now, right? And that's an easy win. Or getting away from plastic cups. So surgery is also moving away from plastic cups and sort of bringing in your reusable cups. So engaging them in that conversation. And of course, we've got the wellness kitchen that are looking at virtual care as well. But what's really interesting in those models is that there's a social benefit. They don't have to pay for parking. I mean, AHS parking is extortionate. They don't have to worry about coming in. There's all those big social impacts as well. So it's work in progress right now. My hope is to have the patient advisory team sit on our committee so that they can see how we can really start engaging patients. Other comments and thoughts?
I think we're approaching the top of the hour, Bhavini, and people are going to need to head off. So thank you so much. That was wonderful. And who should individuals reach out to if they're interested in getting more involved?
Just reach out to me. I know Steve is working with me from a zonal lens as well. But yeah, I'm happy for people to reach out, especially if there's interest in embedding this in QI. We can get the physicians trained up. We're going to be running multiple workshops. So it'd be great to get the physicians trained up in this as well in your QI team.
Great.
Wonderful. Thank you so much for having me. I really appreciate it.
Yeah, no, wonderful talk. Thank you so much for doing this.
Thanks. Bye-bye.